Post-traumatic stress disorder can be considered as very, very bad anxiety and depression following a traumatic event. Its manifestation is in three parts. One is avoidance, so you avoid reminders of the event, or you might avoid talking about the event or talking about your feelings. The second is re-experiencing, so you might have bad dreams, you have intrusive ideas, which means these memories come into your mind of the event without you wanting them to. And so we talked about avoidance and re-experiencing, and the last symptom set is hyperarousal. So you have an exaggerated startle response. You feel very jumpy all the time. You feel always in danger. So when you mix avoidance with hyperarousal with re-experiencing, you start to get the symptoms and the symptom picture of post-traumatic stress disorder. Again, summarized as really bad anxiety and depression rolled up in response to a traumatic event that doesn't go away. As the withdrawal becomes more and more frequent, it becomes more and more debilitating socially as well as vocationally and then eventually interpersonally. And the reason withdrawal becomes more and more pervasive is that it works to reduce the anxiety. So withdrawal is a coping mechanism. The problem is it has very negative side effects. We don't want people to withdraw to cope with anxiety. We want them to confront it or to get better in one way or the other. But withdrawal feeds upon itself. So once it works to reduce anxiety, the person is more likely to do it again in the future. And that's sort of a vicious cycle of increased withdrawal, which leads to increased depression and isolation. And then that perpetuates the symptoms. The public service information, the Department of Defense efforts, and the VA efforts to basically publicize both the problem of post-traumatic stress disorder, PTSD, and its treatment has resulted in greater public awareness and greater public acceptance of this disorder. Now, it's been around for as long as we've had war. We've had people who helped the veterans of war know about this problem. It used to be called shell shock, war neurosis, soldier syndrome. Now it's called post-traumatic stress disorder. So it's been around and recognized for a while, and I think the actual severity of it is what we're now becoming more accepting of. Well, it all goes back to that social withdrawal and social isolation. The more a person withdraws and isolates, the more it's going to impact their lives. So a person may not be able to continue to work. A person frequently won't be able to continue to function as a social individual in society. And humans are by their very nature social animals. So this is a tremendous contradiction as to who we are and who they might be. So I have spouses of veterans say, he's just not the person he used to be. He doesn't want to go out with family or friends anymore. He doesn't enjoy himself. He can't go to the movies. He's afraid of people sitting behind him. My daughter wanted to go to the circus, but he couldn't take the crowds. We have grandfathers who have missed all of their sons' football games, and now they're going to miss their grandsons' football games because when there's a touchdown and the crowd jumps up and roars, they can't stay there. They're too activated. The hyper-startle response, that jumpiness kicks in. And so what do? They withdraw, and as withdrawal continues, it becomes more and more of a pervasive coping style that somebody turns to. And withdrawal might not only be with your feet, meaning you might not only leave the situation, but you might start to use substances and alcohol and drugs to escape the situation. And that has obviously its own problems. So this is sort of an insipid problem that can expand tremendously to every aspect of a person's life. Well, every individual's experience of the traumatic event is different, and every individual's response to the traumatic event is going to be different. And what I mean by that is some people may choose not to talk about it at all. Some people may choose to talk about it all the time. They may become obsessive about protecting their family and friends. Some people may decide they need to live way out in the country, away from everybody. So just as people deal with problems differently, they're going to deal with the problems that these symptoms cause differently. And one of the major things to recall about this disorder is it doesn't seem to go away on its own after about 6 months. So from that 3 to 6 month point after the traumatic event, if you've gotten the symptoms and they're starting to impair your living of life, then it's likely that they're going to persist. Now, that's about 1/3 of people. 2/3 of people get better on their own. They always have bad memories, they might avoid talking about it, but they're pretty much unimpaired. But that 1/3 that doesn't get better on their own, those are the people we worry about and we think they need treatment. About 1/3 in some populations, 1/5 in others. Current treatments that we have were originally developed for victims of severe interpersonal violence. They were then used with disaster victims and with veterans. These programs are based on exposure therapy, and people like Dr. Edna Foa and others pioneered their use. Now, exposure therapy is basically convincing patients to fight that withdrawal and avoidance, to actually get them to do precisely what they don't want to do. Now, initially, that's going to cause a little bit more anxiety and stress, so the art of the therapy is trying to break these situations of exposure down into doable parts. And so if we have a veteran from Iraq or Afghanistan who's very avoidant of crowds, for example, at a big box store, then we wouldn't say, go to that store on Sunday at 3 o'clock when it's extremely crowded. Instead, we'd say, go to the parking lot on Tuesday at 11:30 when there's nobody there. Stay in the parking lot until your anxiety starts to go down. It will go up, it'll peak, and then you'll start to get used to it. And then do that for 5 days. And then go up to the door and do that for 5 days. You don't have to go in, but what you do have to do is wait for that anxiety to peak and then diminish. If you leave during the anxiety elevation, you'll have just taught yourself, if you leave, you'll feel better, and we don't want that lesson. We want them to teach themselves, if I stay, it'll be hard, but I'll start to feel better. And what we do is we teach people, it's like cold water in a swimming pool. If you jump in and jump out, you never get used to it. But if you go into the situation, it may still be uncomfortable, but you start to get used to it. It might never be fun, it might never be comfortable, but you can swim in the pool and start to enjoy other things. For example, other people's company. It's the same with our exposure treatment, and that's the name of the treatment. It's called exposure, prolonged exposure. We identify all of the situations that a person is avoiding, and then we break those down into pieces, and we have them expose themselves to it. And then we also do that with the memory of the traumatic event, because people avoid memories of what happened. Now, these memories still assault them when they don't want them to. So we put them on their own terms, and we have them bring the memories back. We have them close their eyes and imagine that they are reliving the worst thing that ever happened to them over and over and over again. And it's very intense, and people feel as if they're back in the situation, but it's in the safe environment of an office. And if they do this over and over again, the memories start to lose their power to elicit anxiety and to elicit fear, and you start to get used to them. Now, we don't lie to our veterans and say, oh, the memories will get better and they won't bother you anymore. No, of course, these horrible things should always bother you. But we take them from being overwhelming to being bothersome. And that's a key difference. We don't eliminate the memories. We take a lot of the negative power away. And so we mix that imaginal exposure with the real-life exposure, and we have a full treatment plan. But this is a very much no pain, no gain type of treatment. If you're not being bothered by the treatment, you're not doing it right. You have to push yourself. But it's just like working out. If you don't feel sore when you lift weights, you're not working out hard enough. And our veterans understand that concept of an active treatment, and they respond very well to it. The encouragement that we give them when they, for example, initially feel the pain of this or not sure they can go on is in terms of the rationale of the treatment, meaning we teach them why we want them to do this, how we want them to do it, and why we think it'll work. And then we ask them to teach their family this so that they have complete buy-in and understanding of the treatment. And that's where you get your motivation to keep going when, for example, you hit the wall. And so it's an encouragement through knowledge, not through just cheerleading. And in the session, we're just coaches. We don't talk about childhoods. We don't talk really too much about feelings. We talk about how can we get the exposure going now? How can we give veterans their freedom back now? Now look at this. These guys fought for our freedom, and they come back here, and their freedom is restricted. And I don't like that, and I don't want the veterans to accept that. So we teach them to fight for their freedom, just as they've fought for ours, and to put themselves into these situations that cause them to want to leave, but they should be able to be in. A veteran should be able to go to a movie theater and watch a movie. And so we have them fight to get this freedom back. And that's how we motivate them, to really put it in perspective that way. The Charleston site is somewhat unique because we have combined our clinical best practices with our clinical research programs. We have one of the most active clinical research programs in post-traumatic stress disorder in the country here in Charleston. And so our innovations in the clinic are very rapidly in the research side. Our innovations in the research side are very rapidly transferred to the clinic side. So for example, you talked about how do we get these services to veterans who might live a couple hundred miles away. Well, we're now using telemedicine, meaning we can go right into a veteran's home with an encrypted version of something like Skype. And what that allows us to do is save the veteran the drive time, escape the stigma of having to come to a mental health clinic, allow the veteran to still maintain family functions. If you have to drive 2 hours, and our treatment, by the way, is once or twice a week, if you have to drive or leave work very frequently, you may not continue with treatment. So we go right into the veterans' homes with our home-based telemedicine. Another alternative is to go into one of our satellite clinics. So in Savannah we have a clinic, in Beaufort we have a clinic, in Goose Creek we have a clinic. And they can go to an office there, and one of our experts here can do a televideo session to them right there. So we have options, either office-based or even home-based. And now we've started using the tablets, that are so popular. We've even used Android and Apple-based phones for patients who are on lunch break, and the only time they could get their treatment is in the parking lot of their work, out in their car. So we meet the veterans where they're at. About 30 or 40 years ago, the behavioral psychologists recognized that doing the treatment in the context, that is where the problems happened, was the best way to do treatment. But it was very expensive and hard to go to this patient's house and that patient's work all over the place, physically. And now with these new technologies, we can do a televideo session wherever the patient is. We can help them do these exposure types of trials right where they are. And that it's not just on the phone, because that video adds something. We can see facial expressions. We can see when a person is pushing themselves not hard enough or too hard. And so we've used that, what every teenager and college student in the country is using, to help our veterans. Now we've had some issues along the way. There's HIPAA compliance issues, there's confidentiality issues, but our commanding line is, if this is the only way to get the veteran treatment, then we damn well better use this to get the veteran treatment. We always feel like we can improve. There's always room for improvement. And so on our research side, that's what we're doing constantly. So we have studies using transcranial magnetic stimulation to turn off the area of the brain that makes one feel helpless, and at the same time we're doing that imaginal exposure. So we're turning off the I feel out of control center of the brain and having a patient imagine the worst thing that ever happened to them, and that gives them a sense of control over the memory. So that's a very innovative thing. We're using virtual reality for people who just can't seem to imagine. They can't go back into the scene. They can't imagine it in their head. So we have these goggles that they'll put on and put them back in Iraq. And they are in the safety of the office. They know this, but they're feeling the anxiety of Iraq, and we have them do it over and over and over again until they get used to it. So the areas that we have shortcomings, we're trying to address by applying our research clinic findings into our clinic findings. Now, there's always going to be problems of, there's a lot of people coming back who know they need help, or whose spouses know they need help, but they're either too busy with work, or they find mental health counseling too stigmatizing, or they're just too worried to face it. These are the guys that we need to improve our service provision to. We need to figure out ways to make it easier for veterans to get services. And we're trying to do that with the televideo and the telemedicine, and we just need to continue. All of the returning soldiers are now given a brief screen, both on the Department of Defense side when they're exiting the theater for post-traumatic stress disorder, and when they first come to the VA in their initial primary care visits. Now, the problem with brief psychological screens is you can easily say no, no, no to the problems, or yes, yes, yes to the problems. But that initial step of screening for this specific problem of post-traumatic stress disorder has happened and is in place. So we do have that. The more advanced question at this point should be, what types of treatments should we have available for all of those who screen positive for PTSD, and how easily should they be given these treatments? And the VA is trying to give initial appointments within 2 weeks for all veterans, at least for an assessment, and we do that here in Charleston. But we really need to go more than just assessing initially in 2 weeks. We need to start these exposure-based treatments within 2 weeks. But that's hard because of manpower issues. You have all of the people you used to have from the Vietnam theaters and the Korean War, and now we have all of the new guys, but we have more, but not perhaps enough clinicians to do these evidence-based treatments. So here in Charleston, what we've tried to do is put all hands on deck for evidence-based treatments. And we do very few supportive treatments that are not very effective for post-traumatic stress disorder, and the patient stays in for 20 or 30 years. I don't believe in that type of treatment. What I believe in is helping people get out of the VA. So in Charleston, we're able to maintain flow into the clinic because we maintain flow out of the clinic. And I think that we need to start doing that nationwide. We need to have veterans peer counselors for support groups, and we need to have VA counselors focus on evidence-based treatment. The way we get people past the stigma of seeking mental health care is to not really fight that, because it is a stigma. It's going to be hard to be completely rid of it. Public education has gone very far into pointing out that some people need help to get their lives back, and it's not an embarrassing thing to do. What we try and do is really focus on the fact that we are giving you your freedom back. So we don't try and fight the fact that it's stigma. We try and point out that it's worth it. It's worth the time to come into treatment. It's worth whatever stigma or embarrassment you might feel, because 20 years from now, we want you to have lived 20 years as a free citizen, not 20 years as a person imprisoned by post-traumatic stress disorder. So our best fight against stigma is to show how good our product is. And we can't make everybody accept mental health care and mental health conditions. And we don't care about making everybody accept mental health care and mental health conditions as a non-stigmatizing event. We don't care about that. We care about how effective we are. If you have this problem and you fought for our country's freedom, then you deserve to be free. And from there, we move forward. And if we can get rid of some of the embarrassment or some of the stigma by doing home-based treatment or by having separate waiting rooms for our female veterans, then we do that. But we don't fool ourselves into thinking we can completely remove the stigma from mental health care. Instead, we improve our product on the treatment side, and that makes it more compelling. Our local administration, particularly Dr. Myrick, who's the Director of Mental Health, and his Associate Director, Dr. Kluver, have given us tremendous resources. Our PTSD clinic has tripled in size, and in addition to that, we have an entire clinical research team, so we have a lot of providers, both in the clinic and in the research clinics. And that could not have happened without the foresight of our local administration. The number of people coming back with problems is quite high, and not all of them will get help. But if their first experience, if among those who do try and get help, if their first experience is one of delay and wait list and non-effective treatment, then I fear they won't come back for help. And you have delay and wait list and non-effective treatment when you don't have enough manpower to address the need appropriately the first time. Imagine if you went to your doctor for a bad cut and his first treatment was not the best treatment. You wouldn't want to go back to that doctor. Well, the first treatment needs to be exposure-based treatment, but that's very time intensive. Each session is about 2 hours, once or twice a week. In the past, we would see veterans for 20 to 30 minutes once or twice a month, or something in between where we'd see them in a group supportive format. Well, seeing them once or twice a month for half an hour doesn't help. And seeing them in a group supportive counseling format helps very little. If you still have to offer those services, you're not going to be able to do enough evidence-based treatment. So throwing more people at the problem is not the only solution. We need the people who are already there in the field doing the evidence-based treatments. And there's been some pushback from veterans who are very comfortable and used to getting supportive counseling to counselors who are very used to and comfortable to doing only supportive counseling. And when you have a congressional, which means somebody's complained to their congressman that they're getting rid of a supportive counseling group that's been going on for 12 years, my comment is, if it's been going on for 12 years, then it's not effective. Mental health care does not need to be, or counseling specifically, does not need to be lifelong. What needs to be lifelong is community and social support. Veterans peer groups, veterans activities, community assistance in housing, community assistance for veterans in education. These are where we need lifelong support. Veteran business applications for grant funding. This is where we need lifelong support. In terms of manpower, yes, we're going to need more, but we need more in the right way, meaning we need these people doing evidence-based treatments. One of the things we noticed, and we're hearing from the spouses of our veterans, are, you got rid of these symptoms, he doesn't get up in the middle of the night, he doesn't have as many nightmares, he doesn't do perimeter checks, and he can even go to the store for me, but he doesn't really do things of a social nature. He doesn't really want to go out with friends anymore. He doesn't want to do things in the community. So I thought, well, we need to do something to create a point of interface back into the community. Now, the British do something like this for their officers. They put them on trips across the desert, or they have them do team-building exercises to climb mountains or sail across oceans. Well, we have a marina next door, so we developed a program. It's not a VA program. It's a separate nonprofit that is set up to work with the VA called Veterans on Deck. And basically, that is a group sailing program. And what it does is it creates a socially stressful situation that is not easily escapable. And you think, well, why on earth would anybody want to go into a socially stressful situation? Because you have a group of guys, the boat is leaning over, there's loud noise, most don't know how to sail, and you can't really escape it because you're on a boat unless you swim to shore. So the reason we do that is to sort of change the equation from social plus stress equals bad and I must get away, to social plus stress equals fun if I stick with it. And so if the guys work together and communicate, see if you're trying to have social interaction and social communion, then the boat will go. I'm a concrete guy. I like a concrete manifestation of success. If the boat goes, that means we're doing it right. That's how a sailboat works, right? So if they work together, the boat will go. And what has happened is the guys will come down. We go every Friday. We have a separate group for just women, and then we have a separate group for our seriously mentally ill individuals, people recovering from schizophrenia or substance abuse. But Fridays at 2 is everybody. And so we have community veterans who are doing very well. And we have our PTSD patients. And they all come down and interact together. And nobody knows who's a patient and who's a community veteran. We'll have a brain surgeon veteran next to an alcoholic veteran. You don't know who's who because you're working on the boats together. And they actually come down and work on the boats now. And what's happened is they've met other veterans who keep their boats in the marina. They've done deliveries up and down the coast. They come down and work as teams to fix the boats. We've had Citadel cadets, OAF, OEF veterans, and Vietnam veterans working together on the boats. That's community reconnection. That's annihilating social withdrawal and isolation. Now, we could be doing this in a lot of different ways. We do it through sailing and through boats because that's what we have next door to the VA. But that's Veterans on Deck, and what it has done is provided a conduit back to the community for these veterans because social connection is the key protective factor against PTSD. Yes, you need the treatment, but if you have that social connection, the withdrawal is less likely to take over. The avoidance is less likely to become deeply manifest. So for these guys who have been withdrawn for 20 years, this gives them a handhold back to society. Last week we had 18 people show up. It's really taken off in terms of what it's doing for these veterans. We now have 3 boats and we need every one of them because this program is connecting these veterans who are disabled, socially disabled, back with other veterans who are not so disabled, and they become real-life examples for each other. And they look forward to it each week, and they work together, and hopefully we'll be able to expand it to other VAs.